Hello, and welcome to the latest edition of the Olea Educational Webinar Series. My name is Dr. Adam Davis, and I am the Chief Medical Officer at Olea Medical. We have put together a particularly special program focusing on the future of MRI to be held in two installments. Today's webinar will focus on emerging applications and technologies. The next webinar, to be held in a week, will focus on organ-specific imaging, including the direction of MRI diagnostics. For these webinars, we have invited renowned experts in the field of MRI to be with us. Today's distinguished speakers span 3 continents, 4 countries, and 5 time zones. I would like to welcome Dr. Sotirios Bisdas, Dr. Roland Wiest, Dr. Kohsuke Kudo, and Dr. Edmond Knopp. The subjects they will be speaking on include high-field MRI, mobile point-of-care MRI, quantitative susceptibility MR mapping, chemical exchange saturation transfer, or CEST imaging, and lastly, advances in image processing and visualization. I want to thank each of the speakers for taking the time out of your busy schedules to be with us today. With this, I'd like to move on to the presentations. Very excited for our first speaker. Our first speaker is Dr. Roland Wiest. He is a professor of advanced neuroimaging at the University of Bern in Switzerland. He is the director for the Support Center for Advanced Neuroimaging, deputy chair at the Institute of Diagnostic and Interventional Neuroradiology. He's the division head of the ultra-high field neuroimaging and MR methods at the Swiss Center for Entrepreneurship and Translational Medicine. He is a prolific researcher and author, more recently focusing on brain mapping and artificial intelligence, and has special interest in research, development, and validation of automated image analysis tools and their implementation into clinical practice. Dr. Wiest is a recognized authority in the field of ultra-high field MR imaging, and today he will be speaking to us on this subject. Thank you, Dr. Wiest.
Thank you. Good evening, everybody. My name is Roland Wiest. I'm a professor of neuroimaging at the University of Bern, and it's a great pleasure to be part of this exciting webinar today about the future of MRI. These are the disclosures related to my talk today, and my duty will be to make a short introduction into advances related to clinical fMRI. And as you may, all of you know, the clinical ultra-high field MR systems, the Siemens Magnetron Terra, have been certified in 2017. And since then, it's possible to investigate clinical patients with this new kind of system. And the new system comes along with the principal advantages that we know from ultra-high field imaging. So there is roughly a double signal to noise ratio, an improved signal to noise ratio when using the ultra-high field scanner. There's an improvement in the in-plane resolution to sub-millimeter resolution. There is an improvement of a smaller voxel size and 3D imaging for metabolic mapping with MR spectral imaging. And there are advantages related to bold fMRI, to functional imaging, but also to brain perfusion and arterial spin labeling. And I would like just to show you some of these advantages. I would like to start with metabolic imaging. And here, 7 Tesla imaging has indeed a large potential to push and to facilitate clinical magnetic resonance spectroscopy. And this is usually done with pulse sequences with narrowband chemical selective adiabatic pulses that allow to refocus the system and to investigate metabolites in between 1.8 and 4.3 ppm. And this comes also with the advantage of a very effective water and lipid suppression with a low specific absorption rate. this enables the detection of different parameters. So one of these parameters that is promising in that field is the detection of inhibitory neurotransmitters of GABA. This is of special relevance in the fields of psychiatry, but also in epilepsy imaging, where it has been shown that GABA expression is much higher in areas where focal cortical dysplasias extend. There is a second advantage that, for example, you can do proton spectroscopy in order to detect glucose. So this offers a new potential for the depiction of metabolic disorders that are related to an altered glucose metabolism. And of course, there's a huge potential also for the detection of oncometabolites, for example, the 2-hydroxyglutarate, which is a metabolite of the citrate cycle and which depicts the mutant gliomas. Beyond that, there's also the advantage for using amide proton transfer weighted imaging. So for example, chemical exchange saturation transfer itself generates a contrast that is based on an exchange between protons in the free water pool and bound protons that cannot be depicted with conventional imaging. And by that, looking, for example, at the binding of amide protons, it's a technique that is able to detect endogenous mobile proteins and peptides in the tissue. An increased signal, as you can see here, in these tumors has been attributed to increased saturation transfer due to increased concentration of mobile proteins and peptides. And there are different measurements. So beyond the amide proton transfer, the so-called nuclear Overhauser effect signal can also be investigated, which has also the potential to serve as a new molecular imaging marker for glioma graded that is related to magnetization transfer between water proteins and components of the mobile proteins also here. Olea, the company, has put a lot of effort into building post-processing tools for metabolic imaging, and a combination of these two different technologies of magnetic resonance spectroscopy and the CEST constitutes a new approach to investigate genetic makeups of tumors. And one of the potential new biomarkers, and this has also been shown by papers from Dr. Casagrande, is that the ratio in between amide and amine signals, that is between the NH groups, which resonate at 3.5 ppm, and the amine protons, the NH2 groups at 2 ppm, in proteins and peptides enable the differentiation, one hand between low-grade and high-grade gliomas, but also between IDH mutated and co-deleted, 1p19 co-deleted gliomas. And that's what you can see over here. So these are these kind of relations between amine and amide protons for a grade 4 wild type, for a grade 2, and you can see here the 1p19 co-deleted tumor, which shows almost no expression of the amine and the amide protons. And this can be nicely combined with this new method, so with the 2-hydroxyglutarate spectroscopy at 7 Tesla. And so by combining these two kind of methods, you have a powerful tool to discriminate the grade of a glioma non-invasively. The second topic that I would briefly like to touch is the advantage in functional imaging. And there we have different options. We have on one hand task-related classical bold fMRI and resting state fMRI, which is important for the localization of eloquent functions like language or like memory function. You can even combine neurophysiological signals like the EEG together with the fMRI. You can use the EEG as a predictor for the bold signal in order to depict the areas where epileptic spikes are generated. So this is a typical interictal measurement of hemodynamic correlates related to spikes. And we have, of course, advantages in perfusion images. So currently it's possible to do pulsed ASL, the blockwise excitation that uses the blockwise excitation below the isocenter at the neck, or the pseudo-continuous ASL, which excites the whole volume. And both technologies come with a good balance between labeling efficiency and the tissue signal. They have a higher labeling efficiency at 7 Tesla, and they show an increased perfusion signal that is increased by roughly 40% compared to 3 Tesla imaging. Then I would just like briefly also to draw your attention to the advances that we gain in the structural imaging in the advanced patient care. And I would just touch 2 topics. One is epilepsy, where we are able to delineate new lesions, previously unseen lesions, in roughly 1/3 of the patients. So this is our results, and this is in keeping with the literature and with the systematic reviews. In our data set up to now, we identified 32% of new lesions. We had confirmatory scans in 31% of the patients, and roughly 1/3, and we still have negative scans in roughly 1/3 of the patients. I would just like to show you one case over here of a young patient that received its first MRI in 2012. At that time, you saw an ictal hyperperfusion. This ictal swelling was addressed to the peri-ictal examination, but no lesion was detected. Afterwards, this patient underwent 10 MRs in 10 years. And once he went to the ultra-high field for the first time, this cortical dysplasia that can be seen over here was depicted, and the patient was given a diagnosis. So ultra-high field MR can also help to avoid unnecessary follow-up of patients. And this kind of unnecessary follow-ups, they can also be seen in patients that are erroneously detected with having, for example, small unruptured aneurysm. And we looked also in this group of patients with an ultra-high resolution TOFA angiography, and we identified among 30 patients, among the first group that we examined, a confirmed small aneurysm in 1/3 of the patient. But in 20 patients, the diagnosis was revised, and 18 out of these 20 patients, they showed finally a normal vessel. So this is one of the new technologies that enables to turn a patient again into a healthy person. And this is a very promising field, also the detection of these small aneurysms and the rejection of the small aneurysms, because this will save a lot of money and also save a lot of problems for the patient. So to sum up this brief pitch, the advantages of ultra-high field MR come along with the advantages in molecular phenotyping by using new metabolites, by depicting oncometabolites. There is an advantage in functional brain mapping, both related to classical bold fMRI, but also to perfusion imaging with ASL. And of course, there are several new indications that support the lesion detection of different disorders like epilepsy, like vascular disorders, also in microvascular disease, in demyelinating disease as multiple sclerosis, in neuro-oncology, but also in neurodegeneration. So I would like to thank you for your attention, and I'm happy to take your questions.
Dr. Wiest, thank you very much. I appreciate that lecture. It was excellent. I think what I'd like to do is hold off questions until the roundtable after all of the speakers have presented. Thank you very much. I greatly enjoyed that lecture. Our next speaker is Dr. Edmond Knopp. Eddie, if you could turn your camera on. Thank you. Dr. Knopp is the Senior Medical Director at Hyperfine, which was founded in 2014 to develop portable point-of-care MRI. Dr. Knopp was the Associate Professor of Radiology and Neurosurgery at New York University School of Medicine, where he served as Section Chief of Neuroradiology and Associate Chairman for Quality Technology and Informatics. Also, during this time, I am very happy to say that Eddie was also my boss. In 2015, he received the American Board of Radiology Lifetime Service Award. He is a longstanding advisor to the Davos International Diagnostic Course. Dr. Knopp has authored more than 80 publications. He was the principal or co-investigator on 10 research grants. He has given hundreds of international and national lectures. He is globally recognized as an expert in MRI technique and brain tumor imaging. Today, Dr. Knopp will speak to us about point of care MRI. Thank you.
Hi, I'm Eddie Knopp. I'm the Senior Medical Director at Hyperfine and a clinical diagnostic neuroradiologist. Let me share my screen. And I'd like to thank Olea and Adam Davis for inviting me to speak in this webinar talking about the future of MRI. What I'd like to talk to you about is a paradigm shift in MRI where point of care imaging now becomes a reality. And I'd like to share with you our experience at Hyperfine in developing that system and to try to give you some insight into the potential clinical applicability and utility of such a system. I think to start, I'll show a brief 1-minute video just to give everyone a sense of what the system looks like, since most everyone is more familiar with conventional high field scanners in static RF shielded rooms. So let's start with this video. So I think you can tell from this video that we're now talking about the next generation of MRI. MRI, what we would like to call 1.0, back from the 80s, was somewhat clunky and cumbersome and in its infancy. And I'm sure some of you recall some of these systems and the images that they produced. Then there was phenomenal exponential growth of technology to develop what I like to call MRI 2.0, starting in the 90s and proceeding to this day, where large shielded systems at high field strengths and ultra high field strengths proliferated. Basically, bigger is better, kind of the American supersize me mentality, where now we have clinical scanners in the realm of 7T. But what about the next generation? What about point of care imaging? We know we have point of care imaging for conventional radiography, the portable X-ray machine, point of care portable ultrasound, and now point of care portable MRI, what I'd like to call MRI 3.0. And that system exists, and we have created this system through a wide variety of technological advances to enable it to occur. I think first and foremost is the ability to achieve cancellation of radio frequency and electromagnetic interference that exists in a wide variety of environments. That's not necessary with conventional scanners, as you know, because they're in RF shielded rooms. The system is capable of being portable, and key to that is the use of ultra low field strength, 64 millitesla. You have to eliminate the potential adverse effects of projectiles with high field scanners. Systems need to be approved for clinical use. This point of care portable MR system is approved for use clinically in the United States, in Canada, and in Australia and New Zealand, with CE and CA approvals pending right now. Fully reimbursable, and it's being utilized clinically throughout the world in excess of 70 units. Why would you imagine using a point of care device? Basically, it's to answer specific clinical questions when it might be impossible or very difficult to get those answers. Things like acute mental status change, assessment of ventricular size, in environments where it's not really possible or it's not safe. The intensive care unit patient, highly unstable. The COVID patient, infectious, very unstable, not wanting to be transported. Patients on extracorporeal membrane oxygenation and the like. If we can bring the technology to the patient, that paradigm shift, we can obtain images and answer specific clinical questions. Here are just some close-ups of the system as we envision it at Hyperfine. It needs to be fully mobile with caster wheels controlled by a joystick. The system itself is neuroimaging exclusively, and it has an 8-channel transmit-receive head coil, but it's a 15-channel system. Those other 7 channels are used for that active noise cancellation, analogous to headphones, to enable it to exist in whatever environment it's placed in. Again, we're changing the paradigm. We're bringing the MR to the patient. It needs to be a safe and simple methodology to use, and it needs to be plug and play, just like the portable X-ray machine, just like the handheld ultrasound. Bring it to you where you want to go, plug it in, and scan within minutes. And we think that these scanners can address the challenges of traditional MR, again, by bringing MR in environments where it's not possible. In the emergency room, decrease that workflow and that length of stay, in the intensive care unit, or even the operating room, and more importantly, in the setting of global health. There are many institutions and places throughout the world where either they can't afford a traditional MR or it's not possible to site them, given the technical requirements of electricity and HVAC. If you have a point of care methodology that can go into those environments, you can then address these challenges and bring this advanced technology and care to the patient themselves. There are also workflow benefits. We're all used to and accustomed to what it actually takes to take a patient from an intensive care unit, highly unstable, and bring them to the MRI. That MRI needs to be blocked so that no patient is on the scanner by the time the patient gets there, and that patient needs to be prepared and brought down to the MR with all of the ancillary support personnel, nursing, respiratory therapy, and the like, and the potential for adverse events. But if we can flip it, switch that paradigm, and bring that scanner to the patient, we can have a significant time savings and a savings potentially in adverse events. Why would you, or how would you envision using a system such as this? So again, we see the use of the system based on where it's going to be utilized. In the intensive care unit, first and foremost, acute mental status change. What's happening to that patient? How can I find out exactly what's going on? Do I need to intervene and treat that patient emergently? Can I follow pathology that I know is occurring in the brain, but it's too difficult for me to follow on a regular basis? What about emergency room patients? Emergency rooms, we know, especially in this COVID era, are significantly overworked and backlogged. But if we can use a simple point of care methodology to triage patients, not to make finite, precise diagnoses, but to make determinations as to whether it is safe to discharge that patient for further evaluation on the outside, or that patient requires hospital admission and intervention. And then lastly, the setting of pediatric patients. You know, everyone wants to image gently and image wisely with these pediatric patients. But if we can have a way in which the patient and their family can be imaged at the point where they're presenting in a somewhat more friendly environment, that's going to be less stressful and enable more rapid diagnosis to be made. One can think of shunt failure evaluation in the setting of pediatric hydrocephalus. So just to reiterate and to finish up, various value propositions of point of care imaging in this setting, MRI, first and foremost, acute mental status change, wherever it's happening in the hospital. Clearly, in an intensive care unit or step-down unit, it's easier to bring the scanner to the patient sometimes, if that technology exists, than bring the patient to the scanner. post-surgical imaging just to be sure that it's safe to transfer that patient from the operating room to wherever point they're going in the hospital, be it the PACU, be it the ICU, and the like. Not to establish neuro-oncologic baseline in the setting of tumor evaluation, but just to assure safety of patient transport. As we mentioned, pediatric hydrocephalus, image these patients with known ventricular catheters presenting with a new onset headache at the point of their presentation, eliminating the stresses on conventional systems and eliminating the stresses on the family. So I hope I've given you some insight into how point of care MRI can shift the paradigm and bring the technology to the patient. Thank you.
Thank you, Eddie. Excellent presentation. I absolutely love this technology. Innovative, emerging, disruptive. I'm sure we're going to have many questions about it during the roundtable. Thank you very much.
Thank you, Anna.
Our next speaker, Dr. Kohsuke Kudo, is a professor in the Department of Diagnostic Imaging at the Hokkaido University School of Medicine in Sapporo, Japan. He is the recipient of 14 named research grants over the past 18 years, studying cerebral blood flow and metabolic imaging, and has a particular focus on brain ischemia and neurodegenerative disease. He has authored over 250 published papers. He is the recipient of numerous awards from the Japanese Society of Neuroradiology and the RSNA, recognizing his outstanding papers, his presentations, and his contribution to imaging research. He is a recognized global authority on cerebrovascular disease and MRI technique. Today, Professor Kudo will be speaking to us on quantitative susceptibility magnetic resonance mapping. Thank you very much. Look forward to this presentation.
It is my great honor to talk about my research topic in this great symposium. My name is Kohsuke Kudo from Hokkaido University, Faculty of Medicine, and my talk today is Basics and Clinical Applications of Quantitative Susceptibility Mapping, QSM. QSM is a novel method to calculate local magnetic susceptibility using phase information of MRI. Magnetic susceptibility is a physical property which is unique to each substance. It affects the resonance frequency and phase of surrounding protons. SWI is commonly used for clinical imaging, but it is not quantitative. In contrast, QSM is quantitative. Image contrast of QSM consists of two kinds of substances. Paramagnetic substance has larger susceptibility and it appears bright on QSM. Those substances include iron in the cortex and deep gray matter, iron in the hemorrhage, and deoxyhemoglobin in the hemorrhage and veins. In contrast, diamagnetic substance has smaller susceptibility and it appears dark on QSM. Myelin in the white matter and calcium are diamagnetic. High-resolution QSM is really fantastic, even with 3T. Ion deposits in the deep gray matters are clearly seen. When maximum intensity projection is applied, high-resolution venography is obtained. The veins in the basal ganglia and tiny medullary veins can be seen. There are many areas of interest for clinical applications and research topics. For the ion in the form of hemoglobin, the detection of microbleeds including CAA and differentiation between hemorrhage and calcification are clinically useful in daily practice. increased iron in the form of ferritin is observed in patients with Parkinson's disease in the substantia nigra, SLE and MS in the basal ganglia, ALS in the motor cortex, and Alzheimer's disease in the basal ganglia and cortex. By using large susceptibility of deoxyhemoglobin, MR venography and oximetry are achieved.
QSM in the body is challenging because of the inhomogeneity of static magnetic field due to the air or lung and bowels, and motion from breathing, heartbeat, and peristalsis, so you need short scan time. And another factor is that the fat surrounding organs and subcutaneous fat needs frequency corrections. So in the conventional QSM reconstruction technique, you see the artifact in the boundary between fat and other tissue. But we have developed the new techniques which reconstruct the water and fat time maps separately, and then these two are combined into one map. These fat and water separation techniques were applied to liver cirrhosis patients. Compared to the upper row patient, which shows less fibrosis, but in this lower row patient, which shows severe fibrosis, this patient shows increased susceptibility, and the texture in the liver is quite variable. We have developed hybrid sequence of QSM and VBM with Fujifilm Healthcare. We usually use 6 echoes for QSM acquisition, and these phase imaging can be reconstructed into the QSM, and voxel-based analysis can be possible. And this is the magnitude of the first echo, and actually this is the 3D T1 weighted images, so this can be applied to the voxel-based morphometry, VBM. And this last echo can be utilized to make the SWI, and the QSM map can be used to make oxygen extraction fraction map. So this 5-minute sequence for whole brain can be used for many quantitative analysis. Another technique is brain surface correction. This is also developed by Fujifilm Healthcare. Now this is the magnitude images, and this is conventional QSM reconstruction. You see the outer area of the brain surface is masked out, and you cannot evaluate the susceptibility in this area. However, with this BSC brain surface correction techniques, the susceptibility of the brain surface can be evaluated. So we apply this BSC and vein removal for the detection of increased susceptibility in the Alzheimer's disease patients. We collected 80 patients and cognitively normal age-matched subjects. Anatomical normalization with data is applied, and ROI measurement is achieved by using AAL template. And we compare the susceptibility value between AD and a normal patient using conventional QSM and a QSM with brain surface correction. And we also evaluated the efficacy of the vein removal. Now this is the result. Without the BSC, this is conventional QSM, the increased susceptibility in the Alzheimer's disease patient is quite limited, only seen in the precentral gyrus. And if we apply the vein removal, there's no change. However, by using this brain surface correction, we see more regions which shows increased susceptibility in the AD patients compared to the normal subjects. And vein removal is also quite effective to detect the increased susceptibility in AD patients in the orbitofrontal cortex, parahippocampal gyrus, and inferior temporal gyrus. Now this is the result of the voxel-based correlation between amyloid PET and QSM. You see the 15 clusters with positive correlations. And this is the average of 15 clusters. And you see very good positive correlation between amyloid PET and susceptibility in this area. So we think that prediction of A-beta pathology can be possible by using QSM.
As QSM depicts deoxyhemoglobin in the brain, OEF can be quantified by measuring venous susceptibility. When cerebral blood flow decreases, OEF increases and then the amount of deoxyhemoglobin increases in the vein. Here QSM map is divided by rectangular window, and mean and ST of chi are calculated in each window. The venous pixels are segmented in each window using mean and ST values, and finally, absolute quantification of OEF is achieved using this formula.
So we apply this BSC and vein removal for the detection of increased susceptibility in the Alzheimer's disease patients. We collected 80 patients and cognitively normal age-matched subjects. Anatomical normalization with data is applied, and ROI measurement is achieved by using AAL template. And we compare the susceptibility value between AD and a normal patient using conventional QSM and a QSM with brain surface correction. And we also evaluated the efficacy of the vein removal.
In this patient, OEF increase is seen in the right hemisphere in QSM, which corresponds well to PET OEF. On the patient basis, positive and significant correlation between QSM and PET is seen, with the correlation coefficient of 0.62. Brain surface correction is also good for OEF analysis, as more accurate OEF quantification is achieved with more veins on QSM. You can see more veins in the surface of the brain here.
So in summary, a QSM has unique contrast of MRI, which can be used for the estimation of paramagnetic and diamagnetic substances. Increased magnetic susceptibility were noted in Alzheimer's disease patients, especially with brain surface correction and vein removal. A-beta pathology can be predicted by using QSM, and QSM-OEF can be a non-invasive alternative to PET.
Thank you for your attention.
Thank you, Dr. Kudo. Our next speaker, Dr. Sotirios Bisdas, is is an associate professor of neuroradiology in the Institute of Neurology at the University College of London. He is a consultant neuroradiologist and MRI lead in the Department of Neuroradiology at the National Hospital for Neurology and Neurosurgery at the University College of London, and professor of radiology and neuroradiology at the Ebert of Karls University Hospital, Tübingen, Germany. His field of expertise includes advanced and functional MRI, molecular MR PET imaging, ultra-high field MR, and intraoperative MRI. His current focus of work regards MRI biomarkers for applications in immuno-oncology, traumatic brain injury, radiotherapy, and clinical trial design. Professor Bisdas has authored over 200 peer-reviewed publications and 10 book chapters. Today, he will be speaking to us on the subject of magnetic resonance chemical exchange saturation transfer imaging, otherwise known as CEST imaging. Dr. Bisdas, thank you very much. I'm looking forward to this presentation.
Dear participants, thanks to Olea Medical for organizing this seminar and you for joining this visionary session on the future of MRI. I'm glad to present you clinical evidence and my thoughts on the importance of metabolic MR imaging in neuro-oncology. MR spectroscopy and APT-CEST are not the only metabolic MRI modalities, but comprise the clinically and potentially broadly applicable ones. Their role is to enhance our diagnostic arsenal and to provide valid biomarkers for two, so far largely unmet clinical needs. Glioma staging is the first diagnostic challenge since 2/3 of the glioma patients present with WHO grade 2 to 3 tumors, and these tumors have unspecific clinical MRI findings. However, an accurate non-invasive staging is required to guide the patient management, either towards surgery or for a watchful waiting. The second challenge is the accuracy of the post-treatment surveillance in gliomas, in light of the increasingly complex and novel treatments that have uncertain outcome and tend to cause unspecific changes in the brain tissue, just to mention the notorious pseudoprogression. There is a plethora of advanced MRI modalities that can be potentially used to complement conventional staging and surveillance, but I would just refer to perfusion as a classical example. Here, however, I would focus on true metabolic imaging, such as MR spectroscopy and the APT-CEST. MR spectroscopy theoretical principles are probably well known to all of you, but APT-CEST is an upcoming clinical MRI modality that deserves a brief introduction. APT-CEST is a member of the CEST imaging family. The CEST contrast is achieved by applying this pre-saturation pulse at the resonance frequency of slow to intermediate exchanging proton sites, amines, amides, or exogenous agents. APT imaging now refers specifically to the chemical exchange between the protons of the free tissue water and amide groups in endogenous mobile proteins and peptides. So essentially, we are talking about protein and peptide imaging in vivo. Let me show now an example of the diagnostic value of APT-CEST as part of a true multimodal approach. These images were acquired in a hybrid MR PET scanner, and in both cases, we see a stunning agreement between the amino acid PET technique, which is considered reference standard for glioma staging, and the APT-CEST. On the right-hand side, the left insular glioma we see has a moderately increased choline signal, but at the same time, negative findings on both APT-CEST and methionine PET. This was a low-grade IDH mutant glioma. On the right-hand side, however, the right parietal lesion has very low choline signal and negative APT-CEST and PET contrast. This was a case of inflammation. Moving now to another two interesting cases. On the left-hand side, the right frontal glioma demonstrates significantly increased choline value, as well as increased APT-CEST signal and methionine affinity. This was a grade 3 glioma and IDH wild type 1. Last but not least, a case of a non-enhancing right frontal glioma with significantly increased choline and APT-CEST signal. What we see here on the right-hand side is negative methionine affinity, which is the so-called photopenic effect, and it is a distinct feature in high-grade gliomas. In other words, we see that MRI, metabolic MRI, is very robust to detect the high-grade tumor components in gliomas, even when PET does not make it. Interestingly, both MR spectroscopy and APT-CEST probe the tissue in depth. They probe its functional parameters, and both techniques move beyond the limitation of the contrast agent enhancement. On the left-hand side, you see a tumor on the splenium that crosses the midline. And as you see here, we have sampled the tumor, which is, by the way, non-enhancing, in two different locations. The first location is in the bulk of the tumor, and the second location is, as you see here in the screenshot, next to the tumor in the normal appearing brain matter. However, this case shows us that in this area, we have tumor infiltration with increased choline and mildly reduced NAA, whereas at the same time here we have lactate signal, which was not so evident in the tumor bulk, showing that the tissue hypoxia is now moving beyond the visible tumor boundaries. On the right-hand side, we see the impressive ability of APT-CEST to reveal the diffuse tumor infiltration beyond the gadolinium-enhancing areas in two cases. These findings are of paramount interest for the radiotherapy planning and may allow local dose escalation. MR spectroscopy is also ideal as a technique for watch and wait surveillance in cases of new gliomas diagnosis that do not necessarily need to undergo urgent resection. On the left-hand side, the anaplastic transformation is captured by the spectroscopy with obvious increase in choline, decrease in NAA, and new lactate signal 4 months after the baseline diagnosis, and when the conventional MRI has truly missed this turning point. On contrary, the cerebellar vermian lesion, which is not so easily accessible for surgical resection, shows stable metabolic profile 4 months after the diagnosis and can be confidently further followed up without treatment. During the post-treatment period, The case on the left-hand side shows that MR spectroscopy correctly identifies the pseudoprogression in terms of increasing T2 flare signal in a treated glioblastoma. And of course, the spectrum is normal and in agreement with a negative methionine PET finding. However, and by the way, this is an excellent case in a patient receiving Avastin, the perfusion MRI shows treatment response with minimally increased permeability signal and a very restricted area. However, having metabolic MRI, we don't see just only the tip of the iceberg. We see under the surface, and we see the extent of the underlying tumor burden, revising, therefore, the assumed treatment response, which appears here falsely optimistic. In another case that kindly was provided by Lucia Nicelli and Stefano Casagranda, the APT-CEST shows increased pathological signal on the left post-central gyrus. You see that very obviously here. And this was missed by the perfusion MRI, possibly due to the contamination with susceptibility artifacts due to the previous surgery. However, the area which was correctly captured by APT-CEST progressed subsequently 3 months later into a local recurrence, and APT-CEST had provided us an early diagnosis. A visionary application of metabolic imaging, and specifically APT-CEST, would be to personalize and adapt treatment according to the individual response rate to it. In our pioneering study in UCL, we monitored the treatment-induced changes in gliomas during the combined chemoradiation phase. We really appreciate the ability of APT-CEST to pick up changes in the tumor metabolic properties prior to challenges in the morphology. You see here a GBM, IDH wild type, where is followed up during the concurrent chemoradiation. And as the treatment evolves, also we have an evolving decrease in the APT signal, which is the hallmark of initial treatment response. And of course, this is not reflected in the contrast agent enhancement and in the space occupying character of the residual tumor. Such biomarkers are of great prognostic importance, and we are currently expanding our knowledge for the efficacy of chemoradiation, which after all is the cornerstone of any routine clinical treatment. The beauty and unexplored wealth of MR spectroscopy is that offers information for an array of metabolites beyond the well-known ones such choline, NAA, and creatine. With the appropriate data editing, we can create maps of glycine, which is an amino acid where its increased concentration is pathognomonic for high-grade gliomas, and here is in agreement with a perfusion map. And also, we shall not forget that MR spectroscopy is the only in vivo non-invasive technique to measure the 2-hydroxyglutarate levels in high-field MRI, 3T and 7T, and of course, to provide the diagnosis of IDH mutation in a very straightforward manner. To conclude, molecular MRI is a real game changer in the neuro-oncology. APT-CEST is powerful, robust, it's gadolinium-free, and maps the amines and amides which are related and upregulated in tumor metabolism. MR spectroscopy is an established technique, is ubiquitously available. It is also a technique that captures an array of brain metabolites and helps us with non-invasive IDH genotyping. Pre-treatment staging and surveillance to detect the turning point of anaplastic transformation and to prompt therapy start, as well as intra and post-treatment surveillance, are the key and killer applications for metabolic MRI. Metabolic MRI has less constraints in terms of workflow and actually equipment than PET techniques. It's also more patient-friendly. Its commercially available post-processing packages allow for APT-CEST and MR spectroscopy editing and post-processing. And of course, it's an easily interpretable qualitative and semi-quantitative result. At this stage, I would like to thank you for your attention, and I will be happy to participate later in the Q&A session. Thank you.
Sotirios, thank you. Thank you very much for that presentation. Very much enjoyed it. I was very taken with the IDH genotyping early on in the disease. I think that's going to be very impactful. I'd like to discuss that perhaps a little bit more later. Thank you. Great presentation. I will be giving the last presentation in this webinar series. As I mentioned before, my name is Dr. Adam Davis, and I am the Chief Medical Officer at Olea Medical. I was a clinical associate professor of radiology at the New York University Langone Medical Center, where I was the director of the image processing lab in the Department of Radiology. I'm also the CEO of Amalgamated Vision. My areas of clinical expertise include the imaging of cerebrovascular disease, spatial data set visualization techniques, as well as extended reality head-mounted display. Today, I am very pleased to be speaking with you about image post-processing, automation, and data visualization, the software side of MRI clinical practice. So thank you. Let's get started. Adam Davis, and I am the Chief Medical Officer at Olea Medical. Today I will be speaking to you about the future of MRI, image processing, automation, and visualization. These are my financial disclosures, and this is a brief biography. Image processing, automation, and visualization are all about what you do with your MRI data after the study is acquired. It is how we extract meaning from the data we produce and how clinicians share this information. It is important because this lies at the core of the metrics that we apply to demonstrate the value of imaging in medicine. It is all about workflow efficiency, diagnostic quality, and patient outcome. In this lecture, I would like to show you how over the next several decades, changes in how we manipulate and display imaging data, including MRI, will be one of the most significant factors impacting not only medical imaging in industrialized nations, but global healthcare as well. In the allotted time of 15 minutes, we cannot go into detail about each of these imaging components, but I would like to give an overview of image processing, automation, and visualization, discuss its history, the current state of the art, and hypothesize where this might be going in the future. Image processing can be divided into pre- and post-processing. Pre-processing is any manipulation of the original source imaging data in its primary reconstruction format. Examples include denoising or motion correction, and it is done in order to improve the interpretability of the inherent data. What we want to do is bring the image parameters closer to ideal. Post-processing is any subsequent spatial, temporal, or scalar measurement or analysis, and we do this to extract further information contained within the images. Maximum intensity projection, volume rendering, segmentation are all examples of post-processing, a measurement or a reordering of the data in space, time, or voxel value. Correction of case space done prior to the primary reconstruction is not an example of pre-processing that will be discussed in this lecture. Algorithmic pre-processing is using mathematical equations and spatial maps to identify and reconstruct each voxel of the original source data. It is the type of pre-processing that we are most familiar with. Denoising by non-local means, or co-registration and motion correction by rigid or elastic means are examples of algorithmic pre-processing. Many people believe that these mathematical algorithms were developed many years ago and have become a stagnant field. Nothing could be further from the truth. Mathematical algorithms for pre-processing continue to evolve. Earlier, we saw a lecture about CEST imaging. Innovations in denoising, such as principal component analysis, in which signal to noise is differentiated, keeping the spatial and temporal information intact, is the type of innovation that allows for CEST imaging and other types of advanced MRI imaging to occur. Artificial intelligence can also be applied to pre-processing. Artificial intelligence uses ground truth examples and reconstructs the data to resemble the most probable true appearance. AI can be applied to increase the resolution of an MRI. It can also be used for denoising. Examples of algorithmic post-processing include midline detection or segmentation, when the value of the pixel or the geometry of the voxels is used to extract more information or demonstrate some property of the images. Algorithmic post-processing can be more complex. In this case, every voxel in the study is analyzed to look at the time concentration curve in order to find the best candidates for multiple arterial input functions. Multiple post-processing algorithms can be combined for a more powerful analysis. This is an example of software for wake-up stroke when the age of onset of ischemia is unknown. In this case, abnormalities on the DWI and FLAIR imaging are identified and then quantified. The two sequences are combined and a single map produced. The degree of mismatch then correlates with the probable age of onset. Artificial intelligence is often utilized for post-processing. It is generally task-specific, and convolutional neural networks are employed. Complex patterns and discriminative elements within large amounts of imaging data are identified. The results are then pooled and filtered to bring out their most salient qualities. And then, based on a prior given ground truth, the results are continuously modified to arrive at a most likely outcome. A particularly successful example of artificial intelligence in post-processing is the Brain Tumor Segmentation Benchmark Challenge. This is a global competition to develop artificial intelligence algorithms that best segment a brain tumor and the surrounding changes. These have been found to be highly accurate in identifying and delineating not only the tumor, but the elements within and surrounding the tumor, including necrosis, contrast enhancement, and edema. We've now reached the point where image processing steps and automation have become indistinguishable. Automation is defined as the automatic operation or control of a system without human intervention. Modern imaging software uses long chains of pre- and post-processing steps that are arranged in a self-directed, flexible, and branching pipeline, within which the flow of data and the calculations automatically adjust depending on differing inputs and different intermediary results. Image processing can now replicate the manual imaging analysis steps that are traditionally performed by the radiologist. It is widely recognized that this type of automation significantly improves the radiologist's workflow and improves diagnosis. This is a nice example of state-of-the-art, highly automated software. It is used to identify areas of infarction and penumbra on MRI perfusion studies. The hemodynamic maps are automatically produced. These maps are then used to determine the threshold values for areas of infarction and penumbra, which can then be displayed and compared. It can be displayed alongside the diffusion-weighted imaging maps for further information. Different levels, different thresholds of ischemia can also be applied and modified by the radiologist. And all of these results can then be put together in a PDF and exported to a mobile device. I think what we'll see over the next few years is a greater level of automation and a more interactive type of automation. In this demonstration, we see MRI perfusion software in which the MRI sequences are presented alongside the perfusion maps. The perfusion maps are automatically calculated. The radiologist can move through the different images and adjust them as needed, and all of these results are then exported out to a mobile device where the results can be modified as well. Algorithmic and AI-based workflows not only improve throughput, they have been shown to increase the accuracy and improve the reducibility as compared with human assessment. In this study, which was based on the slide I showed earlier, the automatic generation of multiple areas of arterial input function are shown to be more accurate in predicting the area of ischemia as compared with just a single human-identified arterial input function. We've known this for many years. There are studies showing that the automated CT threshold perfusion maps generally are more accurate in the assessment of infarction than those determined qualitatively by humans on a per voxel basis. So where do we go from here? It's true that convolutional neural networks are very task-specific, but what happens when we bring together several different models and we optimize them to work together, and then we apply them to a single study? That's exactly what these authors did. And what they found was that brain tumor detection could be achieved with a 99% accuracy, but more importantly, brain tumor categorization could be achieved between gliomas, meningiomas, pituitary and metastatic tumors with an accuracy of 92%. And the grade of the tumor could also be predicted with high accuracy. I think this is just the beginning of the journey, and we're likely to see more impressive achievements in the coming years. This study out of Stanford showed that MR imaging could be trained against not the classification of the tumor, but against the histopathologic slides themselves. I think what we will start to see is that imaging will act as a surrogate, not a replacement, but a surrogate for pathology when making decisions early in the clinical course. Eventually, this will bring us to a point where our software will be able to create a single comprehensive report, bringing in not only the imaging, but relevant data from the patient's medical record. Our imaging software will not only recognize the MRI sequences, format the display, recognize area of interest, and segment them, but also provide a preliminary histopathology and a grade for a tumor, as well as offer a risk assessment. At this point, the practice of radiology will be significantly changed. I'd like to switch gears and discuss visualization. While we always acquire our studies as 3D volume data sets, we typically convert them to 2D images for ease of review and a faster workflow. However, it's important to remember that that 3D volumetric display contains the exact same data. In fact, if this 3D format is displayed correctly, it can provide an even greater visual understanding of the complex shapes and spatial relationships within the data set, not only for the radiologist, but also for the non-radiology clinician. Here we see a state-of-the-art display. The 2D and 3D images are closely linked in terms of windowing and shading, lighting, localization, navigation. We can see that clicking on an area of interest within the 2D image provides automatic windowing and lighting for the area of interest within the 3D volume data set. We're able to quickly survey the entire area. We can see the relationship of the tumor not only to the breast but to the lymph nodes. In these images, we can see that the user is utilizing a virtual reality headset. They're able to see these images in 3D stereoscopic view, and they're able to quickly and easily move through the entire data set, interrogating the anatomy. How clinicians view radiographic imaging is rapidly changing. We just saw a virtual reality headset, and I'm sure many of you are familiar with this type of immersive, interactive, computer-generated experience. Augmented or mixed reality is a form of virtual reality that layers computer-generated information, digital content, over the real-world scene. Extended reality refers to the full spectrum of virtual, augmented, and mixed reality. Extended reality can be used to convey imaging data for real-time medical practice. These are some of the different headsets that are available for virtual reality, augmented or mixed reality, as well as smart glasses, which can provide reference information for the clinician. In this cartoon, we see a surgeon in the operating room using smart glasses for reference display. They can clearly see the operating field, but they also are presented the radiographic information to guide them during the procedure. This video is given to me by my friends at MetaViz. The operator is using a mixed reality headset, and we're looking at a gadolinium-enhanced MRI of the brain that is co-registered and superimposed on the patient's head in a head frame in the operating room. We can see the tumor, the surrounding brain parenchyma, overlying veins. This is the kind of information that is vital to the surgeon in order to plan his surgical approach, the dissection, and how to resect the tumor itself. When looking at volumetric rendering, it's important to remember that the appearance of the data and the information you extract from the original data set is entirely dependent on the reconstruction paradigm that is utilized. Raycasting is the traditional volume rendering technique, and simulated linear light rays are passed through the data set and then projected onto a 2D surface. Path tracing is a more advanced volume rendering technique. The properties of refraction, absorption, and reflection of the simulated light rays are taken into account. The effect is that this creates a more photorealistic and natural appearance, and it helps with understanding of the image that you're looking at. This is an example of path tracing technique. On the left, a T1 weighted image of the brain. On the right, a diffusion tensor imaging study. We can readily appreciate the photorealistic look of the anatomy, the high conspicuity of the gyri and sulci of the brain, as well as of the fiber tracts. This is another example of path tracing. It is a global illumination rendering of a diffusion tensor imaging study. In the movie on the left, we can appreciate the high conspicuity of the fiber tracts as well as the photorealistic appearance. However, there's a more powerful and a more subtle finding. In the images on the right, in the superior image, the fiber tracts have a normal fractional anisotropy, and we can see that the fiber tracts are uniform and similar in their diameter all throughout their pathway. In the images on the bottom, we can see a DTI where there is abnormal FA. And in these fiber tracts, we can see that the ends of the fiber tracts are thin and tapering. They are attenuated. And this is a nice example of how more advanced imaging can bring out a visual correlate of what is normally a quantitative finding within 2D imaging. I borrowed this last slide from a former colleague, Dr. Desai, who lectures on the use of advanced imaging, in this case path tracing, to simplify subtle and complicated findings. In this example, it is a patient with frontotemporal dementia. The arrows indicate areas of gyral thinning and sulcal widening characteristic for the disease. I think we can appreciate that this photorealistic rendering of the surface anatomy of the brain makes these findings more conspicuous, easier to find than if we had been using 2D imaging. So where do we go from here? It is reasonable to assume that over the next decade, these capabilities will remain disease and task specific, enabling the radiologist to interpret studies more quickly and confidently. As the image processing algorithms improve and the portfolio of AI applications increases and the software architecture evolves, workflow will become more fully automated, particularly for common diseases within a given geographic region. Routine clinical questions such as, is there an abnormality? And if so, is it a mass? If it is a mass, is it a tumor? And where is it located? And what are its margins? And what is its possible pathology? Those common clinical questions will start to be answered accurately and automatically without human intervention. Results will begin to move directly from the modality acquisition to the healthcare provider, who, using improved visualization methods, will have a better understanding of the imaging information and an improved interpretation in a format native to their specialty. Imaging departments will start to concentrate on providing modality management, patient preparation, protocol oversight, quality assurance, as well as the interpretation of that subset of studies that are difficult or ambiguous. As many of these jobs in the workflow no longer require a physician radiologist, it is likely that economics will force a shift towards non-physician healthcare providers for protocol oversight, computer-assisted interpretation, and the communication of the findings. Thank you very much. Well, the last slide was cut off, but I'd like to say thank you very much for your time and attention to all the viewers. I'd like to ask all the speakers to turn on their video, turn on their microphones. Very good. Thank you. Unfortunately, Dr. Kudo cannot join us right now. I'd like to, we have about 10 or 15 minutes for roundtable discussion. We have several questions in the Q&A panel, but I'd like to kick it off by asking Dr. Wiest a question about high field strength MR. The lecture was great, and I really enjoyed being a neuroradiologist. I really enjoyed the correlation of high field strength brain imaging with EEG results. And you mentioned that you saw I believe a 30% increased detection in morphologic abnormalities in epilepsy patients, as well as in aneurysm evaluation. In those patients you did a high field strength follow-up, you found a 60% rate of revision in diagnosis. That's fantastic. So I'd like to ask you, what are the principal advantages of high field MRs compared with traditional magnet strength for routine clinical applications? And do you think that high field strength MR will be applied more widely over the next 5 to 10 years?
Yes, I think at the moment, and thank you very much for the question, at the moment, it's a tool for this so-called second look. So in cases that were either providing conflicting results or where some information is not provided due to a lack in resolution and also a lack in signal to noise, these kind of technologies play an important role. I've mentioned the use case of epilepsy because there it is of particular importance in patients who are refractory to drug treatment. So those patients that are candidates for epilepsy surgery, for example, they need to have an exact description of the extension of a lesion. And this is mainly the cause in malformations of cortical development, especially in focal cortical dysplasia, where also the surgeon want to know what's the extension, what's the true extension of this kind of dysplasia. And there we gain definitely from this increased signal to noise, we gain from the contrast. And as I've shown also, we have an additional and respective number of patients that were previously considered as being normal, or where another lesion also has been addressed as the seizure onset. And I think this is one of these big advantages. Then for the aneurysm, it's resolution. It's this principal advantage of really have this ultra high resolution in order to better depict if there is just an anomaly of a vessel, so if it's just an anatomical variant, or if there is something that needs to be controlled. So we have a huge variety of clinical questions that can be addressed, but it should be noted that the ultra high field imaging is not the first images. So first, a standard MR needs to be done. And given on the results, especially if these results are equivocal and if these results are conflicting, then we usually bring the patients into the ultra-high field scanner.
That's interesting. What about for an application such as demyelinating disease, multiple sclerosis? I would imagine you might have some changes in visualization in those techniques, some increased conspicuity. Do patients ask for high field strength MR? Do you apply high field strength MR in demyelinating disease?
Yes, we do. Especially we do it not on request of the patient. We do it on request of our immunological specialists. And if it comes to early differential diagnosis, so one of the principal advantages of the ultra-high field is the detection of cortical lesions. So once you have depicted these cortical lesions, then the probability massively increases that it is a true multiple sclerosis. You have advantages in the depiction of the central veins, and especially also, and QSM has been mentioned in this talk today, also in these iron rims in lesions, in chronic, slowly progressive lesions. And so there are different advantages from differential diagnosis over monitoring into also depicting other disorders, like, for example, those that are related to other autoimmune diseases.
I saw Dr. Knopp nodding his head. I know he was always fond of bringing out those margins in demyelinating disease. I'm sure he wishes he had high field strength MR at that time.
Clearly now I have the antithesis, right?
Right, the other side of the spectrum. Roland, Dr. Wiest, you spoke to us about the advantages for spectroscopic imaging, and the overlap with CEST imaging is obvious. Perhaps Dr. Bisdas can join us, and I wonder if the two of you could discuss the similarities and the differences between ultra-high field spectroscopy and CEST imaging. There was also a question from the audience about how CEST imaging changes as you move from 1.5 to 3T to 7T. The audience should know that this roundtable is unscripted, and I am as curious as you are to find out what our two presenters think about this comparison.
Maybe I can briefly start with a very simple comment. I would say the principal advantage of MR spectroscopy is that it's a binary decision, which is always easier to make. So either you have to peak for the 2-hydroxyglutarate or you don't have it. And from our experience at the moment, and we are still learning, so we have this at the ultra-high field, we have this still in an evaluation, in a research process. But the diagnostic yield of 2-hydroxyglutarate in our experience at the moment is excellent. So we did not miss up to now any classification, and we started with the first 11 patients, but there was no wrong decision. And in one case where we saw that we had made an erroneous measure, and where we saw this peak, it was a secondary glioblastoma. So there was also, it was confirmed by histology. So I would say just from it's much easier draw the conclusions. It needs less experience also to identify these peaks on MR spectroscopy than on CEST. So maybe Dr. Bisdas, you want to comment on that. But I think the complementation of these two technologies is really the key for the future. So both of them have their advantages. If you bring them together, they are mostly robust.
Yeah, I think there are advantages and disadvantages in each technique. I agree that there is a more or less binary outcome for 2-hydroxyglutarate in MR spectroscopy. And now in my institute, we have examined more than 200 patients at 3 Tesla. So we have worked and investigated a little bit the shortcomings of the, which currently with the technique, but with external factors. So you know how susceptible is MR spectroscopy to artifacts, external artifacts or artifacts related to the field inhomogeneities. So I expect these things, they may be a little bit less at 70, and so the robustness of the technique will be higher. So, but all the cases that we had false negative or false positive results, in all cases, we could attribute that to external artifacts or these kind of shortcomings. And this is easy to understand if you look into the fitting error of the spectrum, or if you investigate a little bit the raw data set. So on the other hand, the APT-CEST can be corrected for all these artifacts or for all these field inhomogeneities by acquiring a T1 map and field homogeneity map. So I think it is more robust, and we don't have the problems that we have with spectroscopy. Here, the binary outcome is either high grade or low grade, which is very similar to the binary outcome of PET. So in that case, they both act complementary, as you mentioned. So you have at the end a composite diagnosis of a high grade IDH mutant or IDH wild type tumor, which is actually the holy grail in oncology.
Thank you. Thank you. That's a nice segue. I'm seeing many questions in the Q&A, Dr. Bisdas, directed to you regarding that. And these questions relate to the future of CEST imaging and its relationship with metabolic imaging. Do you think that CEST imaging will be enough for characterization over the next several years? How do you think?
I think we are nearly there. Yeah.
Right. Go ahead, please.
We are nearly there. We may study a little bit more the reproducibility of the technique. We may study a little bit how the 7T can offer an inherent advantage over 3T. We can look into these issues, but from a purely diagnostic role, I'm convinced that APT-CEST can immediately be applied in a clinical routine for the rough differentiation between high and low grade. And it remains to see its value, whether it can give us more information about IDH mutation, about 1p90q co-deletion, about more molecular markers. But it's prime time for staging, definitely. I think the evidence there, as we showed in a systematic review and meta-analysis, the evidence for the pre-treatment is about the post-treatment.
I'm sorry, Sotirios, we lost you for just a second. Could you please repeat that last?
I just said that we have evidence for its value in the pre-treatment setting for gliomas grading. What we need is a little bit more evidence for in the surveillance imaging, in the post-treatment. If it is efficient, is equally efficient for post-treatment, then I don't see any reason with this immediately as a valid, non-inferior imaging modality to PET or to perfusion or spectroscopy.
Okay, well, you heard it here first. CEST imaging is ready for prime time.
APT-CEST, at least. Yeah.
APT-CEST. I recommend all of our viewers go out and learn a bit more about this. There was another question, and I thank you for, you guys I see are answering the questions directly from our audience. I appreciate that, but I'd like to bring it out to the whole audience. One follow-up question, can CEST imaging be applied to the body parts, to body organs, as well as the brain?
There is research there, but there is nothing which is clinically now valid and applicable. I would probably refer more on the research we have done here about glucose, whole body glucose, where we saw a potential use for lymphomas, for example. And I'm sure that prostate imaging can also take advantage of CEST in various ways. But I don't think that these modalities or in these organs, CEST has reached the level of maturity that we see in brain.
Okay, thank you. Thank you. I'd like to move towards point of care, low field strength MR imaging. Dr. Knopp, many questions from the audience. I'd like to start with a very practical question. For the hyperfine system, is it scheduled for sale in Europe, and what is its CE mark status?
Sure. Thanks, Adam. I had answered that in the question. So we have Health Canada, FDA, and TGA for Australia and New Zealand, and have submitted for both UKCA as well as CE mark. Probably expect those to come through by the end of the year. There are, however, research systems both in the UK and in the EU currently, being utilized.
Okay, thank you. Our audience is fairly global,
Right.
So there's that interest out there. Also, a question that I wanted to ask, and it was also asked by the viewers, several questions. I'd like to know more about the output of the machine. I hate to put you on the spot, but would you be able? Okay, would you be able to share your screen? Perhaps show us some examples of image quality
Sure.
from Swoop. Thank you.
Absolutely. So just to reiterate, we're not a replacement for high field imaging. Just as we heard Professor Wiest say that the 7T was kind of the decision maker if there was a question on 3T or 1.5, we're at the beginning of that chain. So use us as a triage mechanism, rule out something big, bad, and ugly to make a determination. Patient can be evaluated down the road on the outside, or needs to be admitted to the hospital, or needs urgent care. So with that being said, let me show you a smattering of some images, and picture's worth 1,000 words, right? So this is a case. This was a patient that presented with a new onset seizure and a headache to a large academic institution in the Northeast. These are flare images that, if I can get it to go, on top, showing a fairly well circumscribed classic low-grade neuronal glial tumor, the corresponding T2 weighted images. So we can assess extent of disease, mass effect, vasogenic edema, midline shift. This is not a neuro-oncologic baseline. We've heard all sorts of advanced techniques in terms of characterizing tumors. That's not what this is about. This is about a triage in order to make a determination as to what's going on. Another example, patient with a small left-sided epidural hematoma. We can see the extent on the brain with flare, T2, two different types of T1. This is more analogous to a gradient echo type T1 and a flat T1. And again, answer the specific clinical question. And I think the last case that I'll show you, interesting case, patient that presented with a large infarct. This is a flare image. Realize, ultra low field strength flare, conventional field strength flare, ultra high field strength flare, they're all going to be the same. They're nulling out CSF, right? Intraventricular CSF is dark. What we have here is massive subarachnoid hemorrhage. This was a patient status post thrombectomy with a M2 aneurysm rupture, corresponding diffusion abnormality on the DWI and the ADC. So we're answering clinical questions. We made the determination that there is an acute stroke going on and there's acute subarachnoid hemorrhage as well. So I kind of give you a sense, again, we're not replacing clearly 7T, 3T, or 1.5, but trying to image and answer clinical questions in scenarios where you can't otherwise get them.
Excellent, excellent. So principles, obviously, the conventional principles of MR imaging remain the same.
Absolutely.
Level of noise, level of resolution changes, but as a triage instrument, it changes the workflow pattern, brings imaging more quickly to an acute situation.
Exactly.
Okay. You mentioned this change in clinical workflow, making MR more accessible. I understand it's early in the application of the technology. Are there any examples? Are there any studies on this?
So one of our investigative sites, part of the University of California system, is looking specifically at that and the time savings. Basically, what they've found is there's approximately almost a 90% time savings for the ICU patient from the time you order that study to the time it's actually performed. If you realize ICU patients are unstable, you have to free up and block the main MR system, and that may take a day or 2 days in order for that to happen. But if you can bring the scanner to the patient and just scan them at the bedside, you can affect significant decrease in overall length of stay in the ICU or in the hospital itself. And that's going to be published.
Great, thank you. Look, I look forward to seeing that. Thank you, Eddie. We only have another minute. I have a very quick question for you, Eddie, as well. Who performs the acquisition at the bedside? Do you need a specialist? Can any MR technologist do it? Are the clinicians doing it? How exactly does that happen?
The easy, quick answer is yes. So the system is phenomenally simple. Think of your music playlist on your iPod or Spotify, or whatever it is. Basically, you select the sequence and it runs. There's no adjustments to be made. If you want a sagittal T2, you select sagittal T2. You want an axial, it's axial. That being said, what we're finding is there are no government regulatory requirements since there's no radiation. It's basically down to the individual institution in terms of the contracts they have with unions and whatnot as to who can do it. But as you've indicated, all of those varieties of people or individuals are scanning this, are using the system. It can be MR techs, it can be CT techs, portable X-ray techs, research coordinators. There's one example, pediatric hydrocephalus. The children are being assessed and evaluated by the neurosurgical nurse practitioners who then scan the patients. So it's basically up to the institution and the politics within that institution.
Great, fantastic, thank you.
May I ask something?
Yes, please do.
Yeah, so I find it really very exciting, and we are about to start a local trial of the system here at UCL. So what about the MRI safety issues? Is something that we should consider?
So excellent question. And as of, well, let's just talk about for a second, the thing kind of over my shoulder, that shoulder over there, that kind of orange thing is the 5 Gauss line. So anything outside of that 5 Gauss line, there's no magnetic field. That extends 2.5 feet from the isocenter or tip of the patient's nose. Any active device within that right now, we have to recommend you follow normal guidelines. Static devices, it doesn't matter. If it's outside the field, like a backlift and pump, spinal stimulator, insulin pump, there's no effect whatsoever. There's no projectile effect as well. So it's kind of a works in progress, and we're working with MR safety experts, at least here in the United States, Manny Canal and Frank Shellock, to have them submit criteria, because it really can't come from the vendor, regarding MR safety. My sense personally, and I don't know if I should say this on the webinar, but hey, Adam knows me, I'm going to do it, is there's really no effect. Our sales guys put their iPhones in the scanner and take pictures while the scanner is on. But again, it needs to be proven. Stop laughing, Adam.
Yes. As I said to our viewers, this is unscripted and uncensored. So you hear
Exactly.
you hear from everyone what they
now my lawyers are going to get on my case, but what are you going to do?
Okay. Wonderful. I think we've gone over our time limit actually, but I thought the conversation was so animated, so interesting. I thought we would extend beyond that. I would like to thank the speakers for their time, for their expertise. Really, myself, everyone at Olea very much appreciates that. I'd like to thank the people at Olea who put this entire symposium together. It took a lot of hard work, and I'd like to thank our viewers for their time and their attention. Please tune in for the second installment in a week on the future of MRI. Thank you, everyone. Take care and have a good day.
Thank you.
Thank you. Bye-bye.